Bismillahirrahmanirrahim. We were discussing about the joint diseases, and in the previous lecture we discussed about osteoarthritis. In this lecture we will discuss about the rheumatoid arthritis. And rheumatoid arthritis is a chronic systemic inflammatory disorder that may involve many tissues like joints, skin, blood vessels, heart, lungs, and muscles. But principally it affects the joints, producing a nonsuppurative, proliferative, and inflammatory synovitis that often progresses to destruction of the articular cartilage and ankylosis of the joints. It is often said to be autoimmune disease. Rheumatoid arthritis is said to be an autoimmune disease. And like other autoimmune diseases, there is a genetic predisposition and environmental factors. They contribute to the development, progression, and chronicity of the disease. So whenever there is exposure of a genetically susceptible host to arthritogenic antigen, citrullinated proteins, resulting in breakdown of immunologic self-tolerance and chronic inflammatory reaction, there is activation of CD4 positive helper T cells and a local release of inflammatory mediators and cytokines that destroys the joint. And HLA-DRB1 and PTPN22 alleles, they are susceptible genetic predisposition genes. CD4 positive effector and memory T cells, they secrete various cytokines. Similarly, interleukin 17 is released from T helper 17 cells, which recruit neutrophils and macrophages, or monocytes. And interferon gamma producing T helper cells, T helper 1 cells, they produce cytokines which activate macrophages and synovial cells. Rank L expressed on activated T cells, they stimulate osteoclast and bone resorption. TNF and interleukin 1 from macrophages, they stimulate synovial cells to secrete proteases that destroy the hyaline cartilage. 80% of the patients, they have autoantibodies to the FC portion of autologous IgG, which are called rheumatoid factors. So mostly they are IgM antibodies, and they self-associate to form immune complexes in the serum or synovial fluid and synovial membranes. So this diagram shows the pathogenic mechanisms. So there is some antigen exposure, some infection in predisposed individuals, and these antigens, they attach to the CD4 T cells, CD4 positive T cells. And these T cells, when they are activated, they produce various cytokines which lead to B cell activation and then plasma cell formation and formation of autoantibodies, then immune complex formation and deposition and joint injury, which ultimately ultimately lead to pannus formation. We will see what is pannus, and that leads to destruction of the bone, cartilage, and fibrosis and ankylosis. Similarly, cytokines, they act on the macrophages and activate the macrophages. And macrophages, they secrete cytokines which activate fibroblasts and chondrocytes and synovial cells. So all these cells, that is fibroblasts, chondrocytes, synovial cells, they become hyperplastic or they become show proliferation and lead to pannus formation. Similarly, macrophages, they release collagenesis, which degrade the collagen type to stromylysine, elastase, prostaglandin E2, and other enzymes, which destroy the articular cartilage, and there is formation of pannus. Osteoclasts, they are also activated by the cytokines secreted by CD4 positive T cells, and these recruit the leukocytes. So this is the pathogenetic mechanism of rheumatoid arthritis. So this diagram shows the comparison of normal joint with the rheumatoid joint. So this is the normal joint on the left side of the figure. This is synovial membrane. This is the articular hyaline cartilage, which lines the joint cavity. And in the rheumatoid arthritis, there is cellular activation, that is macrophage activation, which secretes cytokines. Then plasma cells, they form antibodies. Then T helper cells, which recruit other cells, neutrophils, fibroblasts, chondrocytes. There is proliferation of the chondrocytes and synovial cells, which lead to an edematous mass of tissue composed of granulation tissue, new blood vessels, and cells like macrophages, lymphocytes, and plasma cells. So this is a pannus formation. So this is how pannus is formed in the rheumatoid arthritic joints. Seronegative rheumatoid arthritis is a type of rheumatoid arthritis in which there are no rheumatoid factors. And then these patients, they show presence of anti-cyclic citrullinated peptide antibodies. Anti-CCP antibodies are ACPA antibodies, anti-citrullinated protein antibodies. And the pannus formation produces sustained irreversible cartilage destruction and erosion of the subchondral bone. So there are two kinds of cells which form the synovial intima, fibroblasts and macrophages. And subintima is the loose connected tissue or fat. So these are the macrophages and fibroblasts. This is loose connective tissue. This is synovial intima. So rheumatoid arthritis, as I said, is an autoimmune disease. So pathogenesis, progressive synovitis and pannus formation, destruction of the articular cartilage, fibrosis, and bony and ankylosis. And then clinical features: pain in the affected joints, limitation of the movements, and general symptoms like fatigue, malaise, then serum show rheumatoid factors and anti-CCP antibodies. So morphology: the synovial cells, lymphocytes, macrophages, plasma cells, neutrophils, they accumulate at the joint space and they form an edematous mass, that is pannus formation. And then that leads to fibrosis and ultimately ankylosis, fibrous ankylosis, and bony ankylosis. The affected joints, they are hyperemic and tender, and there may be rheumatoid nodules in the skin. There may be vasculitis and increased vascularity at the affected site, hemosiderin deposits, and organizing fibrin may appear as dry parties. Osteoclastic activity leads to destruction of the synovium. There is penetration of the bone and articular erosions, subchondral cyst, and osteoporosis. Then vasa nervosum and digital arteries are obstructed by obliterating endarthritis, which may lead to peripheral neuropathy and ulcers and gangrene formation. So this is the diagram which I already demonstrated. This is comparison of normal joint with rheumatoid joint. So pannus formation, proliferation of the cells like macrophages, plasma cell, and this is pannus formation. The synovium is hyperplastic, thrown into small villus-like structure, finger-like projections. And then there are lymphoid aggregates containing lymphocytes, plasma cells. The capillaries, they are congested. This is pannus. And then there are rheumatoid nodules formation. This is like a granulomatous reaction. There is fibrinoid necrosis and then palisading fibroblasts and histiocytes. This is the microscopic appearance of a rheumatoid nodule. So how we diagnose a case of rheumatoid arthritis? So clinical features plus serologic features, X-rays of the affected joints. Clinically, patients present with morning stiffness of the affected joints, and the environment of joints is symmetric. That is, both sides of the hands, small joints and joints, finger joints, they are affected. So joints are swollen, warm, and painful. And then there may be some complications like ulnar deviation of the metacarpophalangeal joints. So symmetric involvement, as I said, symmetric arthritis. Small joints, they are more commonly involved as compared to the larger joints. Serum will show rheumatoid factor and anti-CCP antibodies and typical X-ray findings. And sometimes there may be periods of partial or complete remission with or without treatment. So this is the X-rays, bone erosion, bones may be displaced, bone displacement, So this is normal hand. Here you can see the bone erosion and bone displacement. Then there may be a deviation like this. Different types of deformities involved. Giants, osteopenia with erosions, narrowing of the giant space with loss of articular cartilage. So there may be giant fusion, that is, synovial fluid may be more in quantity. So destruction of tendons, ligaments, and giant capsules, they produce characteristic deformities like radial deviation of the wrist, deviation of the fingers, then flexion and hyperextension abnormalities of the fingers, which are called swan neck, and then large synovial cyst may be found, like Baker's cyst in the posterior knee. So that is about the rheumatoid arthritis. Then there is juvenile rheumatoid arthritis. So as the name indicates, the affected patients, they are young, that is before age 16. Etiology is unknown and generally larger giants are involved as compared to adult rheumatoid arthritis. They often contain ENA in the serum, antinuclear antibodies. And systemic disease is more frequent, and they are classified into 7 discrete clinical subsets that may correspond to separate diseases and genetic backgrounds. Morphologic changes are similar to rheumatoid arthritis. So systemic arthritis, oligoarthritis, rheumatoid factor positive polyarthritis, rheumatoid factor negative polyarthritis, and inflammation of a point of attachment of skeletal muscle to the bones, associated arthritis, psoriatic arthritis, undifferentiated arthritis. So all these are subtypes of juvenile arthritis. So eye and hair, that is rheumatoid arthritis and juvenile rheumatoid arthritis.